I'm Dr. Soma Mandal. I'm an internist at Summit Health currently, and I've been specializing both in internal medicine, and for the past several years, my passion has been women's health. In January, I will be joining Hackensack Meridian Health as the medical director of women's health. We are planning on building a center of women's excellence, building out a whole program for women from head to toe. So you think about it, neurology, cardiology, everything, endocrinology, GYN, all in one program to service the women of New Jersey. I trained at NYU. I did my internship and residency there. I was a medical student at NYU as well. And then I came over to New Jersey, and I've been with Summit Health for 11 years. I am also the host of my own podcast, Soma Says, which you can find on Apple Podcasts, as well as on YouTube. And I am the author of 2 books, which I should have brought up already, but my first one came out in 2019 called Dear Menopause, I Do Not Fear You. And my second book, targeted towards South Asian women, but also applicable to all women, called Midlife, Masala. And it's an integration of both Western and Eastern medicine. And I feel that this book can also help people, women who are not South Asian, because there's lots of pearls that can benefit us all. So today we'll be talking not just about menopause, what it is, but to really understand what symptoms it induces, what we go through as women, what to watch out for. Because even though menopause is being talked about more, which is great, I feel that there's still a lot of uncertainty amongst my women patients. And it's interesting to me because even though it's on social media and you see it on TV more, women are still confused as to whether they should start treatment or not, whether they are candidates, whether it's safe for them. And they have a lot of questions. And hopefully this talk will help you. And of course, at the end, we'll take as many questions as we can. And then I have a QRL code for anyone who wants to scan my slides. I'll leave it up for later so that you can get a copy of my slides. So why does this talk matter? This talk matters because menopause affects over 50 million women in the United States. As I mentioned, it's discussed, but often still misunderstood. And decisions often rely on outdated data. And I'll talk about that later, but what I'm specifically referring to is the Women's Health Initiative, which came out in 2002. And there is new FDA and international guidance that is emerging. So why do I do what I do? If someone had told me in medical school that I would be focusing on women's health, that I would be talking about perimenopause and menopause, I would have been, what are you talking about? That's not what I want to do. I thought I wanted to be a dermatologist or go into cardiology, and women's health was not on my radar at all. Fast forward to having my own practice and then going through my own trials and tribulations. So I became a guinea pig for women's health. And it basically all started while I was still in New York, and I was about 37 years old. And out of nowhere, I gained 10 pounds. I was working out every day. I had a personal trainer. I was eating what I thought was healthy. And I could not explain why I had gained that much weight and why it was so difficult to get off. And in my mind, I thought, I don't understand what's going on. Before, I used to be able to lose the weight just by working or skipping a meal. And now it seems to just be sticking to my body and in all the wrong places, my belly, my breast. And so it was a very confusing time. And then I got married, and I got married at an older age. And believe it or not, and I figured all of this out later, during perimenopause, I became pregnant with my daughter, and I didn't even realize that I was perimenopausal. And the events of pregnancy were also related to my perimenopause. During my pregnancy, I had a lot of symptoms, but one of them was I just was spotting all the time. And the second was when she was born 5 weeks early, and I had a placental abruption. So my body the placenta didn't take, and it was an emergency C-section. But many years later, after reading and talking to different doctors, I figured out that I had low progesterone. And even though I was a doctor, went to medical school, did training, called myself a women's health specialist, I didn't know that I had a progesterone deficiency. And guess what? Progesterone is the first hormone that decreases during perimenopause. What age does perimenopause start? Can anyone take a wild guess? What do you think? Yeah. It could be in your 30s. Yeah. So it could be 36. The average age of perimenopause is 42. And people don't even realize it. And I was one of them because I didn't realize that I was having symptoms of perimenopause. I was having irritability, anxiety, chest discomfort, palpitations. I mentioned the pregnancy, and horrific, heavy periods that were uncontrollable. These are all signs of perimenopause. And there's more, but those were my signs, and I didn't even know it. I didn't even realize it until I started consulting with other doctors, GYNs, who knew a little bit more about this than I did. And after I put it all together, I was like, why isn't there more information about this so that when we come to this stage of life, that we're not left feeling confused and scared? And that some of us, I've had patients who've told me that they're not able to leave their homes because of their menstrual cycles, because they may be having bladder leakage. And these are all things that happen during this stage of life, and nobody talks about it. Why do we have to get to this place and then find out the hard way? Not to blame our mothers, but this wasn't talked about. This wasn't, because I don't even think they were aware of these things themselves. I don't think my mom was aware. And I look back to my mom during that time when she was probably menopausal and perimenopausal, and it was chaos. There was chaos in the house. She was irritable and angry. She was suffering, and she didn't know what was going on. So to transfer that to me, I don't think they had the words for it. But our generation does. We are inquisitive. We ask our doctors what's going on. We should be challenging diagnoses and treatment methods. I feel like we have the power to change that for the next generation, for our daughters, for our grandchildren, so that they don't have to be living in this place of confusion. My other why is my family history. There's heart disease, there's Alzheimer's, there's diabetes, and all of these are additional risk factors. And menopause on top of it can also put me at risk for those things. So I want to try to understand while I'm in my youth to try to prevent these things as much as possible. And obviously also help you, as well as other women, understand how to lower their risks for certain conditions as well. So what is menopause? Menopause, it's a natural biologic transition. It's physiologic. If we're lucky enough, we'll all go through it. The average age of menopause is 51, but menopause can happen in your 40s. It can happen all the way up until your late 50s, which is an outlier, but it can happen like that as well. Perimenopause, as I mentioned, the average age is around 42, but it can start as early as your 30s, and it can go on forever. Perimenopause for me, and I'm giving away some TMI right now, was 30, I'm guessing 38. And guess what? I'm still perimenopausal, and I'm 54 now. So this rule that menopause is a certain amount of time, perimenopause is a certain amount of time. There are women who go beyond that. So the official definition of menopause is 12 months without a menstrual cycle. We don't use labs, although that can let us know what's going on with your body. But the official diagnosis is 12 months without a menstrual cycle. That one day after that 12-month period, you are considered postmenopausal. Sorry. So perimenopause, this is the land of chaos where the hormones just fluctuate. If you look at a graph of your estrogen and progesterone during premenopause, when you're ovulating regularly, you will see that it's like a natural rhythm and it looks like hills, like natural hills, rolling hills. But during perimenopause, your estrogen can be high, your estrogen can be low. And that can happen within an hour. Your progesterone doesn't necessarily go high, but it's also chaotic. And testosterone can also be affected as well. So when you look at graphs of women during perimenopause, it's often, like I said, the land of chaos. A lot of women during this phase ask for lab work. And I always tell them, we won't necessarily determine that you're perimenopausal by your blood work. It can give us a little clue, but you can have labs that look totally premenopausal. And that doesn't mean you're not perimenopausal, because then why are you having erratic cycles? Why are you having night sweats, hot flashes? Why are you having insomnia? So we use the labs as a little peek as to what's going on, but really the diagnosis is clinical based on what symptoms you're having. Menopause, as I mentioned, is 12 months without a period. Postmenopause begins 1 year after your last period. And timing matters for treatment options, which I'll get into later. That there's a timing hypothesis as to when to start hormone therapy. So it really matters that you pay attention to when your last cycle was, when you became menopausal, because these are all important data points to share with your practitioner so that they can determine when we should start treatment for you. What are the common signs and symptoms? I included a few, but really the list can go on, and I don't want to crowd a slide, but hot flashes, night sweats, brain fog, anxiety, mood changes, irritability, weight gain specifically in the middle, fatty liver, bone density loss where you see osteopenia and osteoporosis, vaginal dryness, low libido, skin and joint changes. I have patients who complain about buzzing in the ears, dizziness, headaches, nausea, tingling in their hands and their feet. And we've worked it up and we can find nothing. And so we go back to perimenopause and menopause. Now, a lot of women say, my doctor put me on Lexapro for my depression. Do you think that it may be just perimenopause and menopause? It depends, really. If you have a chronic history of mood issues, if you have depression and anxiety, and that precedes your perimenopause and menopause, then most likely there is a component of a mood issue there. But these hormonal imbalances that happen during this stage don't necessarily help. So we have to really be careful in saying, okay, everything is related to perimenopause and menopause. It could be a combination of both. So we will talk more about all of this, but there's, as I mentioned, osteoporosis, increased risk of fractures. I mentioned fatty liver. And then in some women, there is data that shows that there's cognitive decline, Alzheimer's, dementia, and other dementias. And then I will go more into the increased risk for heart disease, as well as the genitourinary syndrome of menopause. Now, this is the new terminology that we're calling atrophic vaginitis. And what that means is when your vaginal walls have become thinner, drier, making intimacy more difficult. You may be having more urinary incontinence, more itching in the vaginal area. but this is the new terminology that we call atrophic vaginitis. Women can lose up to 20% of bone mass in the 5 to 7 years after menopause. 1 to 2 women over 50 will have an osteoporosis-related fracture. And this is really important because as we get older, especially when we're in our 70s or 80s, it increases our risk for mortality, death. So by not getting treated for menopause, and then our older years when we're more fragile, more at risk for falls, this can actually increase our risk for death. Women are twice as likely as men to die within a year after a heart attack, and estrogen may help delay the onset or severity of Alzheimer's, especially when initiated early. So some myths that we should go over. HRT, hormone replacement therapy, is not dangerous for everyone. It should be a decision that you make with whoever your doctor is. Menopause is not just hot flashes, and it's never too late to treat symptoms. And there are non-hormonal options, both medicinal and non-medicinal, that may relieve some symptoms. And you have choices. We're not our mom's generation where they were told, you better get off your hormones because you are going to get breast cancer. We have options, and it's just time to learn about it. So the Women's Health Initiative came out in 2002, and it really changed the surface of women's health. It was one of the largest NIH-funded study of postmenopausal hormone therapy. I was towards the end of my residency then and just starting to get my bearings about how to prescribe hormones. And it was at that time, and this was before it officially came out, so there were already warning signals that were going out into the medical community. Tell the residents, tell the doctors to stop prescribing hormones. Why? Because women are at higher risk of stroke, women are at higher risk of breast cancer. Now, there is important data that we've learned from this study, so I don't want to just toss it out altogether. However, one of the confounding factors of this study was that the women were older than any of us in this room. The average age of the women that were studied were 62. So naturally, if you're in that age group, you are just by age going to have a higher risk of breast cancer, going to have a higher risk of heart disease, going to have a higher risk of stroke. And then the other confusing part of this study is that they were not using what we call bioidentical hormones. What I mean with bioidentical is that the hormones that we currently prescribe or should be prescribing are molecularly exactly alike with our own natural hormones. The hormones they were prescribing were synthetic hormones. They were equine estrogen, so coming from horse estrogen, and a synthetic progesterone. And so we do think that especially with the synthetic progesterone, that increased women's risk. But what we did learn from the study was that the estrogen arm only, the women who got their synthetic estrogen, actually there was a decreased risk of breast cancer as well as a decreased risk of heart disease. It was in the arm of the women who got both estrogen and progesterone where they saw higher risks of everything. So we now know that the women are older, right? That they were being treated farther out with their menopause than we currently recommend, and age was a confounding factor. But what happened was for 20 plus years, women like my mom's generation lost out on hormone therapy. And we are seeing higher rates of dementia, higher rates of heart disease, higher rates of everything because of that, of osteoporosis, because they missed out on hormone therapy. And My goal is to prevent that with our generations and generations below us as well. Media didn't do any justice. They caused panic. Many women stopped HRT overnight because doctors like myself would not prescribe it. I was told you cannot prescribe hormones anymore. So I stopped. And then for 20 years, I stopped basically because this is what the idea was. We got in misinformation. And when the findings were later reanalyzed, like I mentioned, the risks were age dependent. The media was portraying it as a 26% risk of breast cancer, when in reality, it was really 8 in 10,000. So yes, a slightly higher risk, but guess what? A glass of wine a night puts you at higher risk of breast cancer than hormone replacement, if that puts it into perspective for you. And it resulted in decades of confusion and undertreatment for a whole generation of women. So we'll be talking about updated treatment options. I mentioned bioidentical hormone replacement. There are newer medications like Diosa that work in a different kind of way. We'll also be talking about other topical treatments, and if we have time, complementary treatments as well. So hormone therapy, estrogen and progesterone, this is considered the gold standard of treatments. There's nothing else out there that treats the brain fog, the night sweats, the hot flashes, the insomnia, as well as hormones do. Yes, you can take your magnesium glycinate, you can take your melatonin, but if your body is depleted in estrogen and progesterone, none of those medications are going to restore that. And there's also a word out on social media called balancing your hormones. There's nothing that balances your hormones. When your ovaries stop making those hormones, you're not going to balance anything. So really, the gold standard for these, what we call these vasomotor symptoms, the hot flashes and night sweats, is HRT, hormone replacement. And it relieves hot flashes. This is estrogen therapy. Hot flashes, night sweats, vaginal dryness, although we'll talk about the vaginal dryness in a minute as to other treatments. Mood issues, and if started early enough, it can preserve bone density, it can reduce your risk of heart disease, it can support brain health, and there are various forms. My go-to is the cheapest, which is an estradiol patch, which is generic, it's cheap, it's bioidentical, but there are creams, there are tablets, there are gels and sprays that you can use as well as a vaginal ring. Now, the reason why I prefer the patch with my patients is because it's transdermal and it skips the liver. So when you skip the liver in terms of metabolizing, when you take an estrogen tablet, that goes through your liver and that increases your risk for blood clots. So preferably to minimize that risk, the patch, a transdermal option, is the best way to go. With progesterone, required for women with a uterus to prevent endometrial cancer. So if you take estrogen by itself, your endometrium wall will start building up. So the progesterone is for two different reasons. One is to basically prevent your endometrial lining to not build up because that puts you at higher risk for endometrial cancer. But the second is, like I mentioned, it's the first hormone that goes down in perimenopause. So it's also a part of the HRT. It's also part of hormone treatment. So there are women who may go on estrogen. They may have an IUD, like a Mirena IUD. That's a progesterone treatment right there. They may not need oral progesterone or a progesterone cream. They can use the progesterone IUD, the Mirena IUD, as their progesterone treatment itself. So testosterone and menopause, it's like a lot of women are curious about what treatment options there are. I do prescribe testosterone. Really, every patient of mine that goes on hormone therapy, it's a tailored treatment. I don't just throw everything at them and then sit back and see how they do. I treat it little by little to see how they're responding to, let's say we start with estrogen and progesterone first, And then if it's not necessarily better, we'll do some testing. And testosterone is one of those hormones that I do like to check, even in perimenopause and menopause, because if a patient is not responding well to the hormones that I'm prescribing for her, standard estrogen, progesterone, that I may throw in a little testosterone in there, because that, especially if they're having hypoactive sexual desire issues, their libido is down, or they may not feel motivated, testosterone can do the trick there. But it's really, you have to really know your patient to be able to be comfortable doing that. I prefer working with compounding pharmacies. It is not yet approved by the FDA. A whole group of doctors did go to the FDA in July to lobby for testosterone to be part of the menopause treatment, but we're still waiting on that. And you may have heard of some of them, Dr. Kelly Casperson, Dr. Vonda Wright, Dr. Mary Claire Haver. They all went to the FDA, but we're still waiting. So right now it's not FDA approved. There are pharmacies that compound it, and I usually prefer a cream or a gel that you can use in your thighs. A lot of doctors use pellets, which are little kind of like Tic Tac kind of pills, and they insert it into the skin of your gluteal muscle, and it just infuses. And you can do that with any hormone, really, estrogen, even progesterone. But a lot of doctors do it that way, and patients find it less cumbersome. But I usually use the gels to treat. So osteoporosis and bone health, bone loss during menopause is well documented. I've tracked a lot of my patients as they get older, become menopausal, and I basically watch their bone density. And for most women, the bone density just starts just going down and down. And that's just what happens. Estrogen is one of those hormones that supports bone health. And when that gets depleted, we're more at risk for osteopenia, which is a stage before osteoporosis. And then that's what puts us at higher risk for fractures as we get older. But really, we need more trials, more research, specifically in perimenopausal women to test low dose or preventive strategies. And the studies combining hormonal therapies with newer bone agents or lifestyle interventions in perimenopausal women are also very limited. So we need more research when it comes to that. This one is a big one. What do you think the number one cause of death in women are in the United States? Yeah. And you'd be surprised how many people don't know that, how many women don't know that. And even with my patients who have a strong family history of heart disease, when I start talking about screening in their 50s, they're like, why? I'm not having chest pain. I'm not feeling short of breath. It's very strange to me that we're not aware of this as women. And heart disease and menopause go hand in hand. 5 years after menopause, our risks of having a heart attack, of having heart disease, equilibrate with men. Estrogen is a protective factor, but whenever menopause is for you, 5 years after that, even if you don't have a family history of heart disease, your risks of heart disease just automatically go up. So early menopause increases that. So if your menopause is before 45 years old, then you have an even higher risk, cardiovascular risk. And guess what? You know, the hot flashes that people joke about, the persistent ones, patients who are constantly having hot flashes and night sweats, they're running to the bathroom in the middle of the work because they're drenched. That puts you at higher risk for heart disease. It's somehow a mechanism that the body sends a signal that something is not right vascular-wise. So I always tell my patients, okay, yeah, we're going to treat your hot flashes and make sure that you're comfortable at both work and home. But we also, concomitantly, we have to do some screening for you as well. And during this stage, when women are going through perimenopause and menopause, and you may have seen it in your own labs, your cholesterol, your blood pressure, insulin resistance. They basically worsen faster. Even if you're eating fruits and vegetables, you're limiting what you're eating, you're exercising, you're sleeping well, our metabolic system just changes. And that is obviously a risk factor as well. Women, as I mentioned, are historically underaware of heart disease and the screening lags. Hormone replacement, when begun earlier, may offer some cardiovascular benefits in appropriate candidates. But really, the timing is very critical. So we think that if you start HRT, hormone replacement, let's say at 60, you may not get the same benefits as if you were 55. So we need more studies, like I was mentioning, in when it comes to heart health and menopause. What we don't know is the inconsistent definitions of perimenopause, the limited randomized control trials, and the limited diversity in the study populations. The lack of diversity when it comes to women of color is a real thing. And that's why one of the reasons why I wrote my book, to try and equalize that. But timing also matters. The timing hypothesis, whether you're initiating hormone therapy early versus late, and we need more randomized control trials in that area as well. What I'm also curious is, what level do we need to get patients' labs to during menopause, right? That will reduce their risk of heart disease, that will reduce their risk of stroke. These are the areas where we need more trials and studies to see what we can do to reduce our risks of these conditions. So the bulge in the middle, the muffin top, the pants, we start wearing the stretchy pants, but these are driven by hormonal shifts, and the visceral fat that happens, it's not benign. These are areas of inflammation, and it feeds our arteries and causes more plaque formation. It's metabolically active and it's inflammatory. And even with a normal body mass index, BMI, which I hate, the high visceral fat increases cardiovascular risk. And I don't use BMI in my practice because, especially with South Asian women, because we are at higher risk for heart disease, diabetes, all of it, even with a normal BMI. And I often use waist circumference and other markers like your lipoprotein A and your cholesterol panel, and obviously your family history as well. So there is some evidence that earlier menopause is associated with increased dementia risk. We need more studies here. Many of the studies that are there are retrospective. There is some recent news that menopause may shape Alzheimer's risk in women, but we need more longitudinal work. We need to understand neuroinflammation and mitochondrial function and trials, specifically in perimenopausal women. There are some interesting, and I have some patients enrolled in these trials at Cornell, where they have an Alzheimer's prevention clinic, and they are actually running a longitudinal study on perimenopausal women and menopausal women and how it affects their risk of dementia. And a lot of these patients actually have a strong family history of dementia, Alzheimer's specifically. So it'll be interesting when the data comes out. How many of you have experienced the brain fog? Estrogen is the hormone that's responsible here. And the reason why it affects your serotonin, your dopamine, acetylcholine, and these are neurotransmitters that affect your moods, your cognition, your focus, your sleep, and your memory. And so when these get affected, you feel like you're in a fog. Brain fog, forgetfulness, difficulty concentrating, they're more common in perimenopause. Don't know why. I see it less in my menopausal women. And the mood swings, the irritability, the low motivation, can mimic anxiety and depression. And I mentioned this earlier, it can often be tricky because women come in feeling irritable and they automatically get put on an SSRI like Prozac or Zoloft or something like that. So we have to tease apart what's going on, right? Is there a chronic history of this? Has something triggered it? Or is it perimenopause? Or is perimenopause making things, their underlying mood issues, worse? And estrogen, progesterone, it's not just estrogen, it's a combination of all three. Progesterone, testosterone all play a role in our brain chemistry. So I mentioned the muffin top and the girth that happens in the mid-abdomen. The thing is now we have tools. 10 years ago, okay, we had the GLP-1s, but they were not as efficacious as they are now. And when Ozempic and Wegovy became a thing, and now Mounjaro and Zepbound, it was the bane of my existence. Everyone wanted to be on it. No one wanted to pay for it. Nobody's insurance was covering it. They were all begging my office to get it authorized when they didn't have the coverage for it. But now I'm the one who's bringing it up with them. Have you thought about using a GLP-1? Not to each and every woman, but I think of it as a tool that we didn't have before. So if I see that, yes, you're perimenopausal, menopausal, your sugars are running high, your cholesterol is running high, you have a family history of heart disease or stroke, why not? And now not everyone can necessarily afford what the direct online pharmacies are selling it for through Novo Nordisk or Lilly Direct, but it's actually come down in pricing. So I think of it as tools that are in our belt now that we can use as long as you know someone who can confidently prescribe it for you and knows what they're doing. But we also know that in combination with hormone replacement, the GLP-1s are the most efficacious when they are used with hormone replacement itself. You will see more weight loss than you would with just the GLP-1 itself. But in addition to that, obviously, it can't just be all about your medications. You have to sleep right. So getting you to how to sleep properly, and that could be hormone replacement, but also sleep hygiene, how to reduce your stress, exercise, what you're eating. So there are often times when I encourage my patients to use a health coach, which can really do the work when I'm not there, and they can be accountable maybe through an app or directly with their coach to track what they're eating, how they're sleeping, and that can often be very helpful for women itself. There's emerging evidence that menopause may increase the risk of fatty liver, and I've seen that in my own patients. Metabolic syndrome, insulin-resistant visceral fat are well documented, but which changes are driven by menopause per se versus lifestyle versus genetics versus age are unclear. So we need more studies when it comes to that. So I was mentioning the GUSM, genitourinary syndrome of menopause. I have many women who come into my practice saying, I think I have a UTI. 48-year-old woman, UTI. I'm like, I've tested your urine 5 different times within the span of 2 weeks. You don't have a UTI. I'm having burning, itching. I think I have a yeast infection. I've also checked that for that. You don't have a yeast infection. Guess what? They have this, otherwise known as atrophic vaginitis. So the estrogen that gets depleted during perimenopause and menopause also affects our vaginal areas. The tissue thins out. We're more at risk for painful sex. Some of the symptoms are urinary frequency, incontinence, vaginal dryness, itching. These are very common symptoms. And this affects a large majority of postmenopausal women. It's also seen in perimenopause, and it typically worsens over time if it's not treated. And guess what? It also increases our risk for urinary tract infections. So my women who are actually having UTIs, I always put them on a little bit of some vaginal estrogen because that reduces the risk of UTIs as well, and obviously treats the condition and treats the symptoms as well. So vaginal estrogen, there have been many studies on it. Thousands of women have been studied. It is completely safe. Without any concern for my patients who have breast cancer, I put them on it. Maybe not on hormonal treatment, like systemic hormonal treatment, but this is completely safe. And at a certain age, I believe in your mid-40s, every woman should be on some vaginal estrogen. I talked about the health coaches, and this is also an important one, advocacy. I've been the woman who has been on the opposite side, where I've been the patient. I've had to advocate for myself, sometimes using strong language, sometimes telling the doctor that I'm a doctor myself, right? But I've also been on the other side, where I was going too fast and my patient had to slow me down and I almost missed something. So I've been on both sides. But for someone who's been on both sides, what I understand is you really have to advocate for yourself. You can't just go in and say, you know what? I'm feeling really tired and I can't concentrate and I'm feeling depressed. I don't know what's going on. Go in there, make a list of what you're having. I think I'm perimenopausal. Be direct, okay? Show up on time to your appointment, maybe even 15 minutes ahead of time. These days, doctors are very pressured, seeing multiple patients, huge volumes of patients. We're running. So if you show up late, it just puts more stress on the system. Show up on time, bring a list. A lot of people apologize to me when they come in with a list. It actually makes my job easier because we get through things faster. So make a list and say, I think I'm perimenopausal. Be direct with your doctor. And then see what they have to offer. If you feel your doctor isn't well rehearsed enough with this, then it may be time to switch to someone else. There's no shame in that. That doesn't mean that doctor is bad. But unfortunately, both in medical school and in residency, I myself did not receive any training when it came to menopause. I think I remember something like, if your FSH is above 20, that likely means you're menopausal. I don't even know what that means, but that's like the Cliff Note version of menopause. It really wasn't focused on. So that doesn't mean your doctor is bad, but they may not be well rehearsed. And it's time to move on. Now, there are different platforms. There are online platforms like MIDI and all sorts of other places that are focusing on perimenopause and menopause. But there are also many people in the community who are trying to catch up to this. But we also need to do our part and be more direct with what we're going through. And if you're told your labs are normal, it's just aging, maybe it's just stress, possibly, but no one knows yourself like you do. I don't know you as well as you do. So if you think that there is something going on with your body, then you should advocate for that. Thankfully, there's more public advocacy, which is changing the stigma. Hopefully people like myself and other doctors who are coming out on social media, telling their stories. There are people like Claire Gill. She's the CEO of the National Menopause Society. She is a big advocate of women and their stories. And she was one of the women who went to the FDA to lobby for more treatment when it comes to menopause. And I think of this stage of my life as not the end. I think of it as an opportunity. Menopause, even though I'm not there yet, it has this way of telling you, you know what? It's time to fess up to what's going on. And for these past 5 years, that's where I've been living, where I have been telling myself there's something not aligning with what you're doing. I love my patients. I love going into work, but I knew there was something more that I wanted to do. And I'm using it as an opportunity to reinvent myself, to have a voice, to write more, to have a podcast, to become the medical director at Hackensack of Women's Health. So this is not a time when we should go away. I know it's a transition where some of our kids may be going off to college. We may be becoming empty nesters. There may be career changes, but it is also an opportunity to really focus on yourself, your interests, your hobbies, and reinvent yourself as well. These are some of the resources. Of course, I'm promoting my podcast and my book, but I also love Dr. Kelly Casperson. I love Tamsin Fadal. She has a great voice out there, talks to many women, doctors who help us understand. The books that have made a big impact on me are Estrogen Matters. Midlife Masala is the book that I recently wrote. The New Menopause by Mary Claire Haver. She's coming out with a new book called The New Perimenopause that you might want to look out for. How to Menopause. The Menopause Moment was written by Kelly Casperson, and Unbreakable is a book that was recently written by an orthopedic surgeon that focuses on menopausal women, Dr. Vonda Wright. And I included some of the podcasts as well as my website if you want to look for me.